So when you picture, cutting edge medicine, what do you actually see? I'm guessing it's not two people just sitting in chairs talking. You're probably thinking MRI tubes, robotic surgery, maybe complex genetic labs.
Sure, the high-tech stuff.
Exactly. We have this kind of cultural idea that our health is all hidden in the data, just waiting for a machine to find it.
Well, it's a very comforting thought, isn't it? This is just certainty. The machine says you're sick, so you're sick. The scan is clear, you're fine. It sort of removes the human element.
But today we're diving into a source that argues, well, pretty much the exact opposite. We're looking at this comprehensive postgraduate guide for ENT history taking. That's ear, nose, and throat.
Right.
And the whole idea here is that the most powerful, most sophisticated diagnostic tool a doctor has isn't a scanner at all. It's a conversation.
And, it's not just a casual chat. That's a critical distinction to make right off the bat. This isn't just asking, how are you feeling? We're talking about a highly engineered, almost algorithmic interrogation. The premise in this guide is that a huge percentage of diagnoses, some people say up to 90% in ENT, are basically made before the doctor even touches the patient.
90%, that number is it's wild to me.
It puts a tremendous amount of pressure on that verbal history, doesn't it?
Yeah.
If you mess up the questions, the physical exam that comes after is almost normal. It's just theater. You're looking in the wrong place because you asked the wrong things to begin with.
So our mission for this deep dive is to deconstruct that conversation. We're going to see how a doctor can turn a really vague complaint like, my throat feels weird, into a precise medical theory.
Exactly.
And honestly, I think this isn't just for doctors. Knowing this stuff changes how you act as a patient.
Oh, absolutely. It's about learning the language of the detective work. If you know what the detective is looking for, you can just hand them the clues.
So let's start with the foundation. The guide calls it the universal framework. And I was surprised by how rigid this is. I just assumed doctors sort of flowed with the conversation.
Right, picking up threads as they go.
Yeah, but the source says that approach is actually dangerous.
Dangerous is the right word. Yeah. The guide warns against what they call the shotgun approach, just firing off random questions based on a hunch.
Okay.
You see, the human brain is a pattern matching machine, right? So if you walk in holding your ear, my brain immediately just screams ear infection. And if I'm not careful, I stop looking for anything else.
The confirmation bias just kicks right in.
Instantly. So to strip that bias away, the guide demands a sequential algorithm for every single symptom. Doesn't matter if it's a sore toe, a spinning head, a lump in the neck, you use Socrates.
Which sounds like we're about to get a philosophy lecture, but it's an acronym. SOCRATES.
It is the gold standard for symptom analysis.
Okay, I'm gonna break this down because the nuance in these letters seems to be where the diagnosis lives. S is sight. Where's the pain? That feels obvious. You just point to it.
It seems obvious, but patients are often incredibly vague. They'll say my head hurts or my stomach hurts. In medicine, precision is everything. And in ENT, ear pain is a real minefield because the ear has nerves that connect all over the place, to the throat, to the jaw. So when the guide says sight, it means asking the patient to use one finger and point to the absolute epicenter of the pain.
Okay, next is O for onset. This isn't just when did it start, is it?
No, it's how it started. The speed is the clue. Did the hearing loss hit you like a thunderclap? Just instant silence.
Wow.
That could be a vascular event like a stroke in the tiny blood vessels of the ear, or did it just sort of fade in over 6 months? That's more likely degenerative, or maybe a slow-growing mass. The timing tells you the pathology.
Then deeper character. Describing the pain. Sharp, dull, burning. I always find this question so hard to answer as a patient.
It is hard, but it helps rule out entire categories of disease.
Yeah.
Throbbing usually implies inflammation, high pressure. Burning is almost always nerve-related.
Yeah.
Trushing is muscular. If you can't describe it, the doctor's just guessing.
Right. R is radiation, A is associations. But I want to stop on T, time course. How is that different from onset?
This is the one that trips up the most students. Go to the guide. Onset is the starting line, right? When the race began.
Okay.
Time course is the shape of the race itself. Is the symptom constant? Is it intermittent? Is it getting worse, so progressive? Or is it getting better, resolving?
And why is that distinction so important?
Okay, so let's take a blocked nose, which sounds minor. If you tell me your nose is blocked and I find out it's intermittent, it switches sides or clears up after a hot shower, I'm thinking inflammation, allergies, something that fluctuates.
Wait, it comes and goes.
But if you look me dead in the eye and say, my nose is blocked 100% of the time, 24 hours a day, and it never ever opens, that is a mechanical obstruction.
Like a wall in there.
It's exactly. A polyp, a deviated septum, maybe a tumor, soft tissue swells and shrinks. A solid mass does not. That one detail constant versus intermittent, it splits the diagnostic tree right in half.
The rest of the acronym, E for exacerbating factors and S for severity, kind of wraps it up. It's a really rigorous checklist.
It forces discipline. You can't get distracted by the story until you have these hard data points.
So that's the universal tool. But the guide gets really interesting when it applies this to specific body parts. It turns into this physical detective story. Let's talk about the ear.
The ear is a notorious liar.
Right, otalgia ear pain. The guide makes a huge deal about referred pain.
It's because of the wiring. The ear shares nerve pathways with the throat, the jaw, the tongue, even the voice box. So a problem way down in your throat can send a pain signal that your brain misinterprets as coming from your ear.
So you can have a perfectly healthy ear, but you're in agony holding the side of your head.
Correct, and that's why the guide suggests the jaw connection first. The doctor asks, does the pain get worse when you chew?
And if I say yes,
It's probably not an ear infection. It's likely the temporomandibular joint, the TMJ. That joint sits right in front of your ear canal. When it gets inflamed, it feels exactly like a deep ear pain. I mean, you'd be amazed how many people take antibiotics for an ear infection when what they really need is a night guard for grinding their teeth.
there's another physical test mentioned here, the pinna pull. It sounds like a schoolyard prank.
It's primitive, but it is so effective. The pinna is the outer part of the ear, the part you can grab. If you have otitis externa swimmer's ear, the skin of the ear canal is really inflamed. Pulling on the outer ear stretches that skin.
And I'm guessing that hurts a lot.
It's excruciating. The patient will practically jump off the bed,
And if I pull on it and it doesn't hurt,
but you still have that deep pain. Then the problem is likely behind the eardrum, in the middle ear. The outer scaffolding is fine, so wiggling it doesn't matter. It lets the doctor localize the infection with just one simple tug.
that is clever. Now, discharge, otorrhea. The guide lists the usual suspects, pus, wax, blood. But there was one fluid that sounded like it was straight out of a horror movie. Cerebrospinal fluid.
CSF leak. Yes.
The idea that the fluid cushioning my brain could just leak out of my ear is terrifying.
It is a critical red flag. It usually happens after some kind of head trauma or sometimes skull surgery. The barrier between the brain and the ear is breached.
And the guide gives a really specific way to test for this. You don't need a lab, you just need gravity.
That's right. You ask the patient to lean forward. If it's a CSF leak, the fluid is clear and watery like a dripping tap. And when you bend over, the pressure in your head pushes against that little hole in the skull. The dripping will get way worse.
And why is this such an emergency? I mean, apart from just how gross it sounds.
Because if fluid can get out, bacteria can get in. It's a direct highway for meningitis. You have an open door to your brain. You cannot send that patient home.
Okay, let's pivot to something more common. Hearing loss. The guide breaks it down into two types. Conductive and sensorineural. I've always found them.
Okay, think of it like a stereo system. Conductive loss is a problem with the speaker wire. The sound isn't getting to the nerve. It's blocked by wax or fluid. Sensorineural loss is a problem with the computer itself. The nerve or the inner ear is damaged.
And the guide uses the cocktail party scenario to tell them apart, which I thought was such a relatable example.
It's the classic differentiator. So imagine you're in a loud, crowded restaurant, clinking glasses, lots of chatter, music playing.
Yep, I'm there.
If you have conductive loss, let's say your ears are just plugged with wax, you actually hear better in that noisy restaurant.
Wait, that seems completely back. Why would I hear better in noise? My ears are plugged.
It's a phenomenon called paracusis willesi. In a loud room, everyone else naturally raises their voice to shout over the noise, right?
Yeah.
Well, you have a volume knob problem, the wax, so the background noise is dampened for you. but you get the benefit of everyone else shouting. The signal-to-noise ratio actually works in your favor.
But if I have nerve damage?
Sensory neural loss.
Yeah.
That's totally different. Your ear loses its ability to filter, to pick out the sharp frequency of speech from the dull roar of the background. If the nerve is damaged, everything just becomes this muddy wash of sound.
So if I'm just nodding along at a party with no idea what anyone is saying?
That points strongly to sensory neural loss. The cocktail party effect is a failure of the nerve's processing power.
Fascinating. One more for the ear. Vertigo. The guide is incredibly pedantic about the word dizzy.
It has to be. Dizzy is a useless word in medicine. It means too many things. Do you feel like you're going to faint? That's probably cardiac. Do you feel off balance like you're on a boat? That's disequilibrium.
So true vertigo is very specific.
It's a hallucination of movement. The room is spinning around you, or you are spinning in the room.
And once you establish that it's spinning, the guide goes right back to Socrates. Specifically the T. Timing is everything.
The duration of the spin diagnoses the disease. This is a great rule of thumb. If the room spins for just seconds, like 30 seconds when you roll over in bed, it's mechanical. BPPV.
That's the crystals thing, right?
Loose calcium crystals in the inner ear canals. They float around, hit a nerve, cause a quick, violent spin, and then they settle.
Okay, and what if it spins for hours?
Hours usually implies a fluid pressure issue in the inner ear, something like Meniere's disease.
And for days?
If the room is spinning for days on end, you've likely had a viral attack on the nerve. Labyrinthitis. The nerve is just inflamed and firing constantly. So seconds, hours, days. That timeline can tell you more than an MRI.
Okay, let's move down to the nose. We talked about bending over to test for fluid, but what about just a standard blocked nose? The guide suggests checking for positional clues.
Yeah, this is simple physics. If a patient says, my nose gets way more blocked when I lie down, that suggests the problem is vascular. It's congestion. When you lie flat, blood flow redistributes to your head. The veins in your nose swell up, and the airway closes.
But what if they say, no, it's blocked the same amount whether I'm standing up or lying down?
Then it's structural. A bone spur, a deviated septum, a polyp. Gravity doesn't change the shape of a bone. If it's blocked 24/7, regardless of position, you're probably looking at something that needs surgery, not a nasal spray.
That's a great logic check. Now, bleeding. Epistaxis. The guide has a major red flag here about which side it's on.
Yeah, most nosebleeds are innocent.
Yeah.
No dry air, picking, blood thinners. But those usually affect both sides, or they alternate. The guide warns about unilateral bleeding.
Always the same nostril.
Exactly. If an adult comes in and says, I am only bleeding from the left nostril, it happens all the time and I'm not picking it, you have to rule out a tumor. A mass growing on one side will bleed on that side.
Moving to the throat. There's something here called the 3-week rule for hoarseness.
This is really a public health message as much as a diagnostic tool. If you go to a concert and yell, you'll be hoarse for a few days. That's acute laryngitis. But the vocal cords heal really quickly.
So if you're still raspy a month later,
Biology says that acute injury should have healed. If the voice is still off, something is on the cord preventing it from vibrating correctly. A nodule, a polyp, or a cancer. The rule is hard and fast. In a smoker, hoarseness lasting longer than 3 weeks is cancer until proven otherwise.
that is stark. What about swallowing? Dysphagia. The guide mentions a finger point test.
It sounds too simple to work, but it does. You just ask the patient to point with one finger to exactly where the food feels like it's sticking. And patients are surprisingly accurate. If they point to their neck, the blockage is high up. If they point to their chest, it's lower down.
And then there's the question about solids versus liquids. This felt like a logic puzzle.
It's all about differentiating a plumbing problem from a wiring problem.
Walk me through that.
Okay, if you have trouble swallowing solids, like bread or steak, that suggests a mechanical obstruction. A stricture or a tumor is literally narrowing the pipe. The liquid can slip past, but the chunk of meat gets stuck.
Makes sense. It's a blockage.
But if you have trouble with liquids, you're choking on water, that often points to a neurological issue. Swallowing is this complex muscular wave. If the nerves are damaged, say after a stroke, the timing is off. The fluid splashes into your airway before the muscles can protect it. Solids are actually easier because they move slower.
So solid sticking means a blockage. Liquid splashing means nerve failure.
Generally, yeah, it's a really powerful distinction.
And before we leave the physical stuff, neck lumps. The guide lists features of malignancy. What makes a doctor worry about a lump?
We look for lumps that are hard like a stone, fixed so they're tethered to the tissue underneath and don't wiggle, and counterintuitively painless.
That's the one that always surprises me. I'd assume a cancerous lump would hurt.
Pain is usually a sign of inflammation or infection. Your body is fighting a war, and wars are loud and painful. Cancer, in the early stages, is an infiltrator. It just grows quietly. It doesn't trigger the pain receptors until much later. So a hard, fixed, painless lump is actually much more concerning.
Okay, so we've done the physical detective work, but the guide emphasizes that a patient doesn't exist in a vacuum. You need the context. This brings us to lifestyle.
Right, and this is where we do some math, pack-year calculations.
I've heard doctors use this term. It's a way to quantify smoking history.
Exactly. Saying I smoke a lot is subjective. Is that 5 a day or 40? We need a standard unit of toxicity.
So what's the formula?
It's the number of cigarettes per day divided by 20, since 20 is a standard pack, multiplied by the number of years you can smoke.
Okay, let's do an example. If I smoke a pack a day, 26 for 20 years.
That's 1 pack times 20 years. 20 pack years.
What if I smoke half a pack 10 cigs for 4 years?
That's half a pack times 40 years, also 20 pack years.
So the risk profile is considered similar?
Roughly, yes. And it allows the doctor to stratify risk. A 10-pack year history implies a certain probability of cancer. A 60-pack year history implies a massive probability. It changes how aggressively you hunt for that tumor.
They also asked about your job, and this is not small talk.
No, you're hunting for toxins. Noise is the big one for ears. Factory noise, military gunfire, musicians. This causes a very specific notch on the hearing test in 4,000 hertz.
It leaves a fingerprint.
It does. And chemicals too, like woodworkers, people who sand hardwood floors, have drastically higher rates of a specific nasal sinus cancer. That hardwood dust is carcinogenic. If you don't ask what's your job, you miss the cause completely.
Then there's drug history. We assume medicine makes us better, but the guide uses the term ototoxic.
Which means you're poison. We often forget that the heavy artillery of medicine, chemotherapy, really strong IV antibiotics comes with a cost.
So you could cure an infection but lose your hearing.
Exactly. Drugs like cisplatin or gentamicin can destroy the tiny hair cells in the cochlea. That's permanent hearing loss. If a patient comes in with hearing loss and you don't ask, did you have chemo 5 years ago? Honey, you're chasing the wrong lead.
So finally, we get to the last section of the guide. And frankly, this feels like the most human part. It's titled The Art of the Interview.
This is where you switch from being a scientist to being a healer. The guide calls for professional authenticity.
And it introduces an acronym I think every industry should use, not just medicine. IE. ICE.
Ideas, concerns, and expectations. This is pivotal. Up until now, with Socrates, the doctor is analyzing the pathology. With IC, the doctor is analyzing the person.
So ideas refers to.
Asking the patient, what do you think is causing this? Patients aren't blank slates. They've been living with this. They've Googled it. They have a theory. You need to know what that theory is, even if it's wrong, so you can address it.
And concern.
What is your biggest worry about this? This is huge. A patient with a headache might not actually care about the pain. They might be terrified they have a brain tumor because their father died of one at their age.
So if the doctor just prescribes painkillers and says it's tension, but doesn't explicitly say it is not a tumor.
The patient leaves anxious and unsatisfied. You treated the symptom, but you didn't treat the fear. And you have to uncover the fear to treat the patient.
And expectations.
What were you hoping we could do for you today? Do they want antibiotics, an MRI, a sick note for work? If your plan doesn't align with their expectation and you don't explain why, compliance just drops to 0.
The guide also talks about a technique called signposting.
Think of it like a GPS for the exam. You just narrate your moves. Instead of just shoving a scope in someone's nose, you say, okay, I'm going to examine your nose now. It might feel a bit cold.
It seems like basic manners, but the guide frames it as a clinical technique.
It lowers cortisol. It builds trust. If a patient knows what's coming, they don't flinch, and the exam is physically easier to do.
The guide ends with a warning about pitfalls. The biggest way to fail isn't not knowing the Latin name for a disease, it's just rushing.
Rushing leads to assumptions. If you skip the social history because you're behind schedule, you miss the pack years. You miss the wood dust. You miss the whole diagnosis.
Or failing to summarize at the end.
Looping back is the safety net. So just check, I've got this right. You have left-sided ear pain. It's worse when chewing, and it's been there for 3 days. It gives the patient a chance to say, no, doc, it's the right ear. It catches errors before they become malpractice.
Looking back at this whole document, it's really impressive. We started with Socrates, this rigid, cold data collection.
But we saw how critical those data points are. The difference between seconds and hours of vertigo. The difference between constant and intermittent blockage.
We went through the physical clues, the Pinapole, the gravity test, the terrifying reality of painless lumps.
And the context. The cumulative math of smoking and the hidden dangers in our jobs.
It really shows that a diagnosis isn't a magic trick. It's the result of what the guide calls deliberate practice.
That is the phrase. You don't get good at this by accident. You get good by using the framework every single time until it's muscle memory.
It makes me think about our role, as patients. The guide mentions that one of the ways to gain professional authenticity is to admit when you don't know.
A humble doctor is a safe doctor.
Right. But here's the thought I want to leave everyone with. We've spent this whole time analyzing the doctor's playbook, but a conversation is a two-way street.
Go on.
If a doctor's most powerful tool is the ability to ask Socrates, then maybe our most powerful tool as patients is the ability to answer in Socrates.
That's a brilliant reframing.
Imagine walking into an ER and saying, I have sharp pain in the right lower abdomen site. It started suddenly an hour ago, onset. It's constant and getting worse, time course, and it's an 8 out of 10 severity.
You'd cut right through the noise. You'd be handing the doctor the keys to the diagnosis on a silver platter.
We spend so much time researching the best vitamins or the best exercises. Maybe we should spend a little time learning how to tell our own story. Something to think about the next time you're sitting on that crinkly paper in the exam room.
Be the detective of your own history.
Thanks for joining us on this deep dive into the art of the medical interview. Stay curious, stay healthy, and we'll catch you on the next one.